Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast, your on-the-go source for radiology board review. On this episode, I will continue my review of nuclear medicine Dmsa Scan. And again, this has been the most requested topic that I have had so far, so I'm happy that I'm finally getting to this one. Without further ado, let's get into the questions and answers for this episode. How can you tell an F18 FDG PET-CT scan, that is fluorodeoxyglucose FDG PET-CT scan, with bone marrow stimulation from an F18 sodium fluoride PET scan? The issue when you have prominent bone marrow stimulation on an F18 FDG PET-CT study is that sometimes you see the bones super well, and you could be led to think that this is a bone scan at first glance. However, you need to evaluate the image and especially look for uptake within the brain. And if you see prominent uptake in the brain, this is an FDG scan. It is not a sodium fluoride PET scan. If you see brain uptake and it is a PET scan, it is an FDG PET scan, and not something else such as a sodium fluoride PET scan or even a flucyclovine scan or dotatate scan, with the exception that you can have some pituitary uptake, especially on a dotatate PET-CT study, but you will not see diffuse uptake throughout the brain like you would on an FDG PET image. Next question. If you see cardiac uptake on a general nuclear medicine scan, what agents should you think of first? Cardiac uptake on general nuclear medicine scans generally make me first consider sestimib scans, thallium scans, or an MIBG scan. Cardiac uptake, on the other hand, is not typically seen with gallium, indium, iodine, or free technetium. As a reminder, on an FDG PET scan, cardiac uptake is variable, but you typically will have some uptake. It's just that the degree and distribution of uptake can vary. And if you are doing dedicated cardiac PET scans with FDG, that will require strict patient preparation instructions and protocols in order to be more reliable as to whether cardiac uptake should or should not be present to allow you to identify pathology. That is definitely worthy of a separate episode, and I will get to that in time. But for now, if you see cardiac uptake on a general nuclear medicine scan, the first agents I would think of are sestimib, thallium, and MIBG. Next, what type of general nuclear medicine scan is most characteristic on board exams for having really high cardiac and kidney uptake? So you have heart and kidney uptake. Which scan is that most characteristic for? I told you that cardiac uptake can be seen with sestimib, thallium, or MIBG, but if you see really high uptake in both the cardiac and kidneys, I would think specifically of sestimib. That is a technetium scan, technetium sestimib. Remember, this is one of the myocardial perfusion agents, so cardiac uptake would be expected. Other uses of sestimib include things like molecular breast imaging or breast-specific gamma imaging, in which technetium sestimib is used for breast cancer imaging evaluation. Sestimib is also used for parathyroid adenoma imaging. Bowel uptake on a sestimib scan is also common, and this can cause problems on a sestimib myocardial perfusion scan because you can get scaling artifacts if you happen to have really hot bowel in close proximity on the image to the inferior wall of the heart. Now, thallium can also show heart and kidney uptake, but the reason I think you should think of sestimib first if you see that pattern is that you are simply much less likely to be shown a thallium scan of the whole body. We will talk more about that later, but generally in nuclear medicine, thallium scans are obtained specifically of the heart, so you would not see a whole body scan, or for evaluation of brain lesions. And again, you would get dedicated images of the brain on a board exam, but not a whole body scan. So if you see a whole body scan that has cardiac and renal uptake, I would think sestamibi first. Note that MIBG should not be confused with MIBI, MIBI, sestamibi. MIBG is a separate scan. It is a norepinephrine analog, and it does have cardiac uptake, but MIBG is not classic for really high renal uptake. Next, what are key signs that a scan you are looking at is a fluciclovine PET-CT study? The first step is to identify that you are looking at a PET scan, and I've already provided some tips on how to help you with that. You should look to see the superior imaging quality of a PET scan compared to a gamma camera imaging scan. As I've also said, I would look for brain activity. If you see brain activity, it is an FDG scan. If you do not see brain activity, a fluciclovine scan is still on the table. If there is no brain activity, the next thing I do is look at the pancreas. If the pancreas is super hot, this is probably a fluciclovine study. Hepatic and muscular uptake are also common with fluciclovine PET-CT studies, and with a fluciclovine PET-CT examination, the protocol is such that you start to scan very soon after injection, and you start to scan from the pelvis up. So urinary and bladder activity should be at a minimum, because your goal of imaging on a fluciclovine study is to start that imaging before you have significant renal clearance and accumulation of radiotracer within the urinary bladder. Contrast that to an FDG scan where you typically have an uptake time of about 60 minutes, and you typically start from the top of the head or skull base and move inferiorly. With a fluciclovine study, you image almost immediately after injection, you start at the pelvis, and you move out from there. The reason you want to image before you have urinary bladder uptake is that you want good evaluation of the prostate without urinary contamination in the lower pelvis to potentially confuse whether activity is suspicious for prostate cancer. Next, how do I tell the difference on a VQ scan between a Xenon ventilation scan versus a Technetium Dtpa ventilation scan? If you see a ventilation scan and you see multiple different projections, maybe anterior, posterior, lateral, and oblique projections, that is a clear sign that this is a Technetium Dtpa scan. If you see wash-in and wash-out images, and imaging is only provided in a single projection, it is a Xenon ventilation scan. Next, what is the normal distribution of a Thallium 201 scan? The normal distribution of a Thallium 201 scan can show many things, including thyroid, salivary gland, heart, lung, liver, spleen, skeletal muscle, bowel, kidneys, and bladder. Basically, you have a lot of areas of uptake because thallium is a potassium analog, and normal tissues use potassium. However, don't expect a full body scan for thallium on a radiology board exam. You would most commonly see a thallium scan of the heart for viability, or the brain for toxo, which would have no uptake, or CNS lymphoma, which would have uptake, or radiation necrosis, which would have no uptake, versus brain tumor, which would have uptake. Also, there is the less likely scenario that they show you thorax images on a thallium scan, and if they do, they may be asking about a lung-to-heart ratio, which is something that I think is more likely to show up on a nuclear medicine certifying exam or a subspecialty exam rather than the ABR core exam. But nonetheless, I thought I would simply mention it here as well. Next, if you are shown a CSF cerebrospinal fluid CSF imaging study, what is the likely radiopharmaceutical? By far, indium-111 Dtpa is the most common tracer that is injected for intrathecal use. So if you have something like a normal pressure hydrocephalus study or a patency study for a CNS shunt, the radiopharmaceutical of choice is indium-111 Dtpa. Next, if you are shown a gastric emptying scan, what is the most likely radiopharmaceutical? The answer here is technetium 99M sulfur colloid. And the thing to remember is that sulfur colloid, like Dtpa, is very inert, and both of these agents are therefore good for different routes of administration. In the case of CSF imaging, indium-111 Dtpa is inert and has a long half-life to allow you time to see transit through the cerebrospinal fluid and around the brain, whereas technetium sulfur colloid is also really inert and more amenable to simply eating it or potentially drinking it for an esophageal transit and or gastric emptying study. Final question. What are some ways to tell the difference between a Technetium Mag3 scan versus a Technetium Dmsa scan? I hope that you know that both of these are renal imaging agents. Mag3 and Dmsa are both renal imaging agents. With Mag3, you can see the various phases of the radiopharmaceutical as it transits into and out of the kidney and into the urinary collecting system and bladder. So if you are shown images that show renal cortical uptake, transit, and excretion into the bladder, that is going to be Mag3. If you see a time activity curve, that is also likely to be Mag3. And if you see a time activity curve of renal emptying, that is also going to be a Mag3 study. Technetium Dmsa will have renal cortical uptake only, and Technetium Dmsa gets stuck in the renal cortex. And therefore, with a Technetium Dmsa study, you will not see excretion into the bladder. The target organ for a Dmsa study is the renal cortex. The target organ for a Mag3 study, I believe, is the urinary bladder. And with a Dmsa study, you will simply see renal cortical uptake, and it is most commonly used in pediatric patients for evaluation of pyelonephritis, although other indications do also exist. That is enough for now. I hope this has been helpful for you. Remember to check my website, theradiologyreview.com, for a free downloadable study guide on this topic. For those of you preparing to take the ABR core exam, keep studying hard. Remember, you do have to study really hard to succeed on that exam. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.